along. So great you're here, Kelly. So I was asked to provide a focus on hybrid type 3 study that we did. And as I reflected on, and also on lessons learned. And when I thought about lessons learned, I felt like, well, lessons learned started even earlier than that and continued after. So it gave me a chance to reflect on really a 20-year course of health promotion research as a journey. So I'm going to do is very, very briefly just highlight this health disparity that we've been interested in, talk a little bit about developing of this health promotion intervention and some effectiveness research, and then focus specifically on the last three bullets here. The type 3 hybrid effectiveness implementation RCT that we did. Then some really interesting findings that you may have heard a little bit about before, but we'll amplify on adaptation. And also that sets the stage for a really wonderful grant that just got funded that Kelly is the PI on, and I'm the co-PI on sustainment. But the major point is the green here, the lessons learned for implementation research along the way, which I hope you'll find valuable as I reflected on what did I learn that might be hopefully generalizable. So I'll just quickly say this finding I looked at many, many years ago when it first came out, and I went, oh my gosh, a 25-year reduced life expectancy in people with serious mental illness. This is like really startling. And I was medical director of the mental health system in New Hampshire at the time. And I said, well, is this just a unique finding in a number of states in the United States? And then I found this meta-analysis. And this was around international. It wasn't 25 years, but it was pretty much 2 times the higher mortality risk compared to the general population, average of 10 years of life lost. And the major cause of mortality wasn't suicide, it was cardiovascular disease. So I went, oh, this is really interesting and really important. And as I thought about patients that I was seeing and thought about the challenges out there and my interest in kind of medical problems and integration of medical and mental health care, I came across these data around the kind of risk factors in people with serious mental illness that really are a perfect storm. These are the risk factors, by the way, that pile up in the Framingham study around the highest risk factors for cardiovascular mortality: obesity, smoking, diabetes, hypertension, metabolic syndrome, hyperlipidemia. You can see that people with serious mental illness had all of these things. So it just became apparent to me that we should do something about this. And I started thinking like medical model, right? Well, maybe we need to get people on lipids and do smoking cessation and all sorts of things, right? Well, that was at a time where I was medical director of this state system. And I heard about this program in a meeting with the CEOs. And Ken Ju, who's there, who is a wonderful social worker, activist, trained at Boston College here and went up to be CEO of a mental health center. Unfortunately, he's no longer with us. But Ken was this visionary social scientist, really, even though he was a pragmatic individual. He came up with this idea. I heard about he said, there's this In Shape program, Steve, I'd like to talk to you about, maybe you could do some sort of evaluation. And as I learned about it, he had come up with this idea of having some sort of individual fitness assessment, matching people with what he called a health mentor, giving people vouchers to gyms, fitness centers, and having nutrition education, and yes, doing smoking cessation, and then having these so-called celebrations. And he said, Steve, would you be willing to do an evaluation? I said, Ken, this is like the coolest thing ever. This is really interesting. And at the time, I figured, well, can I write a grant fast enough to do this evaluation of outcomes? And he said, well, we'll just look at satisfaction. I said, no. We need to collect more data than satisfaction, Ken. We should do a real evaluation. And I decided to contribute my effort and contribute an effort of a research assistant I had to do this evaluation, to do this outcome evaluation. So the first lesson that I learned was that we think about innovation often as being something that comes from academicians. And the real innovation, I believe, is all around you in communities, people who are out there doing the hard work of trying to figure out how to take on significant challenges. And so the more that you early on build academic community partnerships, there are bilateral benefits that will accrue. These are opportunities where you can bring resources like an evaluation capacity. It's rigorous, not simply kind of looking at satisfaction or something else. And in turn, start what I never imagined to be a series of studies that have gone on for 20 years from this simple pilot study that we did early by providing evaluation. And so the real question here is when you're thinking about these academic community partnerships, think about what you can bring to the table. What can you bring as a scientist? What can you bring in terms of resources? What can you donate or raise funds for? And so we quickly started this process and then wrote an RWJ grant. But I started donating time, and this subsequently evolved into a pre-post study of this program that we published in Psychiatry and Community Health Journal. And you can see it's not the results are less important than to say that we got original findings of feasibility pre-post, and you could see there's some p-values there around some increased activity and some other sorts of things that we saw. And yes, waist circumference down here decreased. So it's like, oh, we got something here. So that really set the stage for thinking about how we might move forward. And so the second lesson that I learned was if you want to move forward from that original pilot study, it's great to think about developing partnership opportunities for effectiveness research, again, where you can bring something to the table. And think about how you can do work that might be conducted in different contexts and settings. Now, this is different than the NIH stage model, where you start with a rarefied efficacy study in a very targeted population with exclusionary criteria. I believe in jumping right into the effectiveness, real populations, real patients, real providers. And so, but doing that in different settings establishes the evidence base and the generalizability. So what I did is I put together an R01 application to NIH. And I heard there pretty soon thereafter that there was a CDC application for something having to do with prevention. So I decided after I put in this NIMH application to put in the CDC application anyway, and maybe do that in a different setting. So the first study that we put together a grant on was in New Hampshire, carefully controlled down the street where we could deliver the intervention and watch carefully. The second study was in Boston. Well, much to my surprise, both got funded. So we actually had a pretty quick setup around a replication trial that occurred about 1 year after the initial trial. Now, the first trial, we found that 49% of the participants had clinically significant decrease in cardiovascular risk. And the people in the InShape versus a comparison, the comparison was pretty robust. It was like giving people a free membership to a health club. So that was where we could have shot ourselves in the foot, but it's a lesson learned also. Our effect size could have been bigger if I did usual care, but we believe that we should give both sides something, and we gave active intervention to the other side, which is InShape, which has a health club membership, but also has the coach, and then this fitness health club membership. So we first study right down the street from our center in Concord, tightly controlled, one mental health center, one YMCA, 49%. Well, we repeated it in Boston, or started that second study pretty soon thereafter, and we didn't get 49%. We got 51%. This was a replication. It was like, and as Karen knows and others, there's not a lot of psychosocial replication studies out there. And so this was like a gold mine. This was like, oh my gosh, I'm so lucky to have gotten funded to do this study. So we did this study in Boston, ethnically heterogeneous. The majority are from ethnic and racial minorities. And we showed generalizability in several YMCAs, several mental health centers at an arm's length away, where we were doing the study in our office in Concord, but our effector arm was in Boston. So this was like wonderful. And this established an evidence-based practice. So then I started thinking about implementation research. And at the time, it was pretty new. That was a time, Karen, when we were going down to Washington and there were like 300 people at the meeting, not 3,000, you know, and I had this idea, well, I should do this implementation study somehow, but how do you do a pilot study? And so I reached out to 4 mental health centers in New Hampshire, and I figured I would have two, an urban and a rural in both arms, and I'd have one get this implementation and the other kind of put in place, kind of a usual care frame where they were going to do health promotion in essence. So there we did a study, and this is where Dr. Ashbrenner came on board and started working with me as a early career investigator, and it was wonderful to have her come on board. And she started helping as a colleague, and at that time as a fabulous coordinator of the study to help think about how we could understand these data. But you can see here that we had at 6 months and 12 months, we had a clinically significant risk reduction in shape versus the control conditions, and that was pretty darn good. And what was really interesting about this was, if you remember, the best outcomes we had in the randomized controlled trials was 51%. At 12 months, we had 60% reduction. Better than the controlled trial in an implementation study. So this was actually really interesting, and I wish I'd written this up, because I met with the CEO of the mental health center, and I said, Peter, this is Peter Janelle, wonderful manager of this mental health center in Manchester. And I said, Peter, you're a positive deviant. And he said, Steve, people have called me many things, but never called me that. I said, you are doing better than the best randomized trial we could do. What are you doing? And he said, I don't know. And so what we found, actually, which I think was, again, I wish I'd written it up. Another lesson: write up some of these qualitative things when you learn them. But the associate director of the mental health center said, I know why we're doing so well. First of all, Peter Janelle, the CEO, the busiest person in all the mental health centers, big mental health center, he shows up at every one of these celebrations and shakes the hand of every one of the participants. So you've got a leader who is showing not a leadership, but who is an internal kind of advocate, who's present, showing. And secondly, he's decided to put the so-called in-shape plan in the chart as a requirement of everybody who's in this program, as part and parcel of the treatment. So this was embedding a practice in usual care with an internal champion who is the CEO. And we've learned since, having a champion, having leadership makes a big difference. So it actually did better than the best randomized trial. So we did that pilot. So we said, well, there's this thing called an implementation research kind of RFA at the time. It was one of the early ones. And decided to do a hybrid type 3, because we knew that we had an evidence-based practice. We knew that by replication trials that it worked. We just didn't know how to get it out there. And I thought a lot about how to present this in the application, and obviously, and I'll show you the specific aims. But the major thing that occurred to me was, most of the readers may not care about people with serious mental illness and obesity and cardiovascular disease, but they might care about whether the two strategies that we test actually are better in certain circumstances. So the final kind of point of my specific aims page was to underscore that this project would help to answer the question more generically: what's the most effective strategy for implementing a new evidence-based practice, especially when it's not routine to the mission, competency, scope of practice, or financing of a healthcare organization? When you got to do something that's out of scope, how do you do it? And at the time, I'd heard about learning collaboratives. I knew about individual site technical systems because that's what we did. We trained individual sites on delivering interventions. So I learned as much as I could about learning collaboratives, brought on board some experts who did this all the time at Dartmouth. And then we wrote the grant, and the following specific aims were what we put in the front of the grant. These are multi-level specific aims. The first was at the implementation outcome to compare regular training in the model and a learning collaborative on top of that to technical assistance with respect to program fidelity that also had training. So each arm got training in the model. One got a learning collaborative, which I'll describe a little bit more, and the other got individual technical assistance at the level of the organizations. So the first outcome was an implementation outcome, fidelity. Were we able to put it in place with fidelity? The second was a service outcome, same comparison. And here we were looking at participation. Could we deliver? Did people participate in it? Did they get the thing? And then the last outcome was at the participant outcome or health outcome, which was to compare observationally compare its results in terms of cardiovascular risk reduction. As you know, in a hybrid type 3 on the right hand, the primary question here is to test the implementation strategies. The secondary question, which is really confirmatory, is to observe and to document effectiveness. That's in contrast to the type 1, where you're asking about effectiveness and you're observing barriers and facilitators. So the type 3 is all about the implementation strategy. You know that it works, but you still want to confirm that it's working if you can. And so we collected those data. And what we applied was Proctor's conceptual model for implementation research and putting it together. And here, as I mentioned, we had implementation outcomes, primarily fidelity, service outcomes, participation, and health outcomes, namely cardiovascular risk reduction. So that was kind of how we thought about it. And this is how it translated into the actual study. So this is a randomized trial of 48 mental health organizations, randomized over 3 years in 3 separate phases. All sites received training in the manualized intervention of InShape. Everybody, all the health mentors got trained. The real question was, if you add to training either A, a virtual learning collaborative, or B, individual technical assistance at the site center, what is the difference in terms of fidelity at the implementation outcome, primary implementation outcome, fidelity, program participation, the service outcome, and secondarily cardiovascular risk reduction as the health outcome, following Proctor's model. And so the learning collaboratives really were all done virtually, all on the web, monthly meetings with coaches, work assignments, problems that we basically adapted what's called the IHI Breakthrough Series Learning Collaborative Model, which has a whole technology around. We adapted it for virtual. We basically had 6 or 8 organizations at a time working the problem, looking at their benchmarks, how are they implementing, learning from each other, practicing quality improvement versus one-on-one meetings between one of our coaches and the individual mental health center as individually tailored technical assistance, which really is the implementation as usual. So is that pretty clear in terms of the comparison? Any questions about that? So that's the comparison. So we had pretty good distribution around, we had 3 cohorts, 8 in each cohort, 8 and 8, 6, at one time. And you can see cohort 1, cohort 2, and cohort 3, and its distribution across the United States in a 48-site implementation trial. And this is a protocol paper that Kelly wrote and published, putting this protocol, which is really a good thing to do. And this was our attempt to kind of put in print what we were doing. And what we did do originally randomizing 55, but then some dropped out. We ended up with 48. So we over kind of sampled, over randomized before we started the study. And you can see that we were able to show, and this is kind of your basic, it's kind of like in an individual intervention studies where you need to show the intervention and the control condition do not differ. This is our demonstration that in terms of the organizational characteristics, so your unit of analysis, your unit of randomization is not the patient, not the participant, not the person, but the organization. The organizations all looked similar at point of randomization relative to rural, suburban, Medicaid patients, annual served, number of people served. And we did this intentionally. We did have some blocking around making sure that there was distribution that was similar on both sides to make sure, even though it was randomized, where we blocked on some certain variables to make sure that these looked similar. So that's and you can see that our retention was really quite good. So in terms of intent to treat, we had pretty good retention on both arms, despite and part of that's because both arms got something. A little bit of difference, but not statistically significant. So what do we find? So we published this outcome paper on a virtual learning collaborative of technical assistance compared to virtual learning and type 3 cluster randomized trial. What do we find? Well, first of all, if you look at the virtual learning collaborative, each one of these sets is comparing the virtual learning collaborative to technical assistance. See that? Each one at 6 months, 12 months, 24 months. And what you can see is that sites with good fidelity, using our fidelity measure for the InShape model, which is a standardized measure that we put together and validated, is that you can see that the virtual learning collaborative did better on each time point with respect to fidelity. So hypothesis number one, does a learning collaborative, is it superior to technical assistance in terms of fidelity? The answer is yes. What about participation? And so what we did was we decided to figure out what's a minimal dose. And we figured that based on our pilot work and our intervention studies, that attending about 50% of the InShape sessions really is kind of necessary to get the thing. So here you can see that once again, that those attending InShape sessions, 50% or more, that the virtual learning collaborative was superior to technical assistance from 3, 6, 9, and 12 months. So fidelity better, participation better. And you can see that we also had kind of enrollment was superior in the virtual learning collaborative, more people enrolled. And to some extent, this is kind of a proxy for reach. So if you think about it, what we found was the numbers of people that the two arms reached, again, in terms of actual penetration of the intervention, was superior in the virtual learning collaborative versus technical assistance. So in each one of these areas, we showed that the learning collaborative was superior to individual one-to-one coaching of the site in terms of fidelity, in terms of participation, and in terms of reach. And you could say reach has usually got a denominator, so that's true. we were just counted the numbers here. Now here's what kind of was a head scratcher. Even though fidelity was better, participation was better, reach was better, the outcomes in terms of cardiovascular fitness and risk reduction were exactly the same. So what this told us, we think, is that the training that each got a good training, right, and got supervised, that actually for a robust training, putting in place an evidence-based practice, they did the evidence-based practice properly, and its actual effectiveness was entirely the same on both arms. So we probably maybe reached a ceiling, or maybe we just did really good training on both arms, and they also could go to the gym and stuff. So you could say, well, gosh, that's disappointing. Well, not really. If you think that uptake, participation, and reach, more people got it, something that was statistically effective, and at least we showed that the intervention was effective. And you can see here, which is pretty cool, is the cardiovascular risk reduction, once again, hit about our level of the best randomized trials. 50 to 60% of those who participated had clinically significant cardiovascular risk reduction. So we replicated once again the effectiveness trial. So what do we learn in this hybrid type 2? We learned that fidelity was almost twice as good in the virtual learning collaborative at 12 months and 1.4 times good fidelity at 24 months. And I'll talk a little more about adaptation in a second, because that became a theme that I really want to move towards. We did see greater participation in terms of 32% greater participation in 50% of the sessions. And we had 40% greater number receiving the intervention. So greater reach, 40% greater got it, even though the resources were the same in both arms. And the organizations, as you saw, were very similar, but similar effectiveness. At 6 months, 51 to 52% reduction in cardiovascular risk, and it got better at 12 months, which was way cool, 62% clinically significant cardiovascular risk reduction. So what were the implications? We learned that virtual learning collaboratives are an effective approach to implementing interventions compared to usual TA, particularly when the intervention is not part of the usual business of the organization. Introducing a new thing that's outside of, think about it, at the time we did this, Medicaid didn't pay for health promotion. They didn't pay for gym memberships. They didn't pay for exercise coaches. So this was a unique finding in terms of when you got to put in place something that's different out, but important to the health and welfare of individuals in an organization that's outside of their normal kind of playbook and normal reimbursed services. Learning collaboratives are better compared to individual technical assistance, superior fidelity, participation, and reach, but similar effectiveness. So, and then, why did was the reach better? Was the intensity of the virtual learning collaborative? Was the problem solving and the quality improvement methods used result in this better fidelity and better reach? Was it peers, site sharing solutions and modeling success? What was it? We don't know. But we recorded the interventions, and we basically saw, what we know is that when you've got one coach talking to a program director, it's very different dynamic than you've got 8 organizations sharing notes on what they're doing. So we think there's a secret sauce in virtual learning collaboratives that really make a difference. Now, what are the long-term implications? Well, we think that this is scalable, and that we can do fidelity, but the other thing that we learned was that it's really important to be a careful observer of what's happening when you're doing these trials. And certainly in implementation science and health system science, process measures are really important. Qualitative measures, really important. So this is where we started to notice and hear about the fact that even though we were supervising people to do the InShape program exactly the way we trained them, they were starting to do things differently than while we trained it. They were starting to innovate or adapt, or whatever you call it, modify. And so this is where we started getting very interested. And we considered a supplementary study. And I guess the lesson here is, when you're doing a big study like this, think about whether you can capitalize on what you're seeing that you didn't expect, and then see if you can study it. Now, Kelly can remind me, I think we wrote a supplement to this. I think you wrote a supplement, Kelly, is that right? Did we get more money for this, or did we just do it on the cheap?
Yeah, we had a supplement funded by NIMH to do a study of adaptations at the end of the 24-month implementation trial.
Mm-hmm. Great, thanks. And again, the thinking, the interest in implementation, I was thinking like, this is like, we're drifting. This is like violating the premise of fidelity. The supreme god of intervention research. You got to have fidelity. And so we started thinking, well, gee, what are they doing? What sort of adaptations? And this is where and I learned a lot from Kelly in terms of this. And I'll just say a few comments here, and then hopefully she'll also chime in here. But we started looking at Wiltsey Sturman's frameworks around adaptations and modifications. And technically speaking, and Kelly, you can help me with this. Wiltsey Sturman talks about fidelity consistent and fidelity inconsistent adaptations or modifications, but there's kind of a nuance here where the types of things that we think actually are adaptations that are creative and responsive and actually maybe even good. I think she tends to call modifications, right? Things that are deviating from the protocol. Is that correct, Kelly?
Well, at least in this early thinking, which
Early
is
thing.
what year is this? This was 2015,
Hey,
this paper.
2015,
So
yeah,
at
ancient
least in
history.
the early thinking, it was, the focus, and also important to understand the context in which these types of frameworks are developed. So Shannon's work is focused on CBT. So
Mm,
she's very interested in adaptations to cognitive behavioral therapy, which the study of that may be very different than studying a complex health intervention we were also trying to use her framework in a new context, in our context, which the framework wasn't initial. And a lot of people are continuing to do that. And I think it's important to think about like what was she, it's a different thing as we experienced to identify adaptations. And their emphasis early on was on the difference between an adaptation that's planned and unplanned. So an unplanned thing in the CBT frame may be negative because it
right.
may be a drift from fidelity versus a planned adaptation where the team talks about something that's changes in the course of therapy. So this was a long time ago that we applied this and did this early adaptation work. And also, I think their thinking may have evolved since we initially did this work.
Exactly. And so the interesting thing is with this supplement and with Kelly's interest in this area, we started to count the adaptations. Figure, oh, there must be a few. Well, wow, adaptations everywhere. We were seeing adaptations. So the virtual learning collaboratives in the blue, the TAs in the red, the total adaptations. You can see that sites with greater than one adaptation. Look at the percentages here. Sites with one greater than one fidelity consistent adaptation, fidelity inconsistent adaptation. You can see lots. So this really got us interested. Like, really? Really? There's that many adaptations? I thought this was bad science. This is not supposed to happen when you're putting in place something with a goal of fidelity. And then a taxonomy that we worked on, and I think Kelly did all these ratings here, I believe. Do you want to talk about what you learned here, Kelly?
Well, I actually didn't do all the ratings. So one thing that's an important also
Oh,
contextual to put the findings into context was the ratings were done by the model
thank
purveyors.
you.
So it wasn't the scientist rating if something's fidelity consistent or inconsistent. We may have had different ratings, which we would have. We turned to the model purveyors who had a pretty strict application of what's fidelity consistent or inconsistent. And that's important to put the findings into context.
Thank you for reminding me of that. I was trying to remember. So in essence, Ken Ju's team, the people that developed this, had very clear ideas of what was in shape. And among the things you can see here, these are we tried to kind of drill down what are the core components. And to tell you the truth, it was hard to get the purveyors, the developers, to really nail what's core and what's not core. And with adaptation, you can modify things that aren't core, but you shouldn't mess with the core stuff. And where we had a debate, a friendly debate, was around the second feature here. We all agreed that a full-time health mentor who was a certified fitness trainer was essential. And a gym membership, number three, was essential, or some sort of fitness membership to give that, to make it available to them. And group celebrations that were motivational, Seems to be important. But Ken Ju, who again was very serious about this idea of social inclusion and having people who have serious mental illness not work out in segregated facilities, the worst of which might be an elliptical trainer in the basement of a mental health center. He felt very strongly that a very important element of In Shape was, in fact, going to a gym in the community, working out in the kind of health community context with others. Now, we said that I think that's a really good aspiration and it really is good around motivating people, but is it core to the cardiovascular risk reduction? And this is where we had a little bit of a debate. So you can see that there were lots of modifications, lots of adaptations, fidelity consistent and inconsistent. Sites with higher number of fidelity consistent modifications achieved 25 to 30% greater risk reduction. Read that again. More modifications, fidelity consistent, better cardiovascular risk reduction. And you can see that, when we did the kind of check, if you did a fidelity inconsistent, if you did an adaptation, if you did a fidelity inconsistent, did it violate the kind of implementation fidelity score? Did it conflict with it? Yeah, that's why there's a negative coefficient. Yes, it confirmed. But here's the really interesting thing. The number of adaptations, and particularly the number of fidelity inconsistent adaptations, was associated with greater cardiovascular risk reduction. That's not supposed to happen, right? And then when we drill down, this is what we found. The place where there was the greatest disagreement was around the health mentor sessions at the Mental Health Agency. In other words, there were some agencies that said, you know what? We are going to try to get people to the gym, but we are going to set up a really nice gym facility in the mental health center and make it integrated into the place where people seek and receive services. We respect Ken Ju's philosophy around social conclusion, but we fundamentally feel like it's just going to work better if we got it down, if we provide a gym, a nice place with the coaches right there on site. And guess what? It worked. And it worked better than what the purveyors put together. So this is a really interesting lesson around kind of adaptations that can occur naturally occurring by the people in the community that may violate the premise of the purveyor. And Kelly was the lead article on this, lead author of this paper on adaptations. So stakeholder-led adaptations with EBP were common, not rare. Adaptations were unplanned, ad hoc, during implementation in response to challenges in the field. And a lot of them were fidelity inconsistent, and one of them actually reduced cardiovascular risk significantly and was a causative agent in that. How interesting. So sometimes we think whether we're the purveyors or the researchers, we're smarter than the people that are out there doing the work. Guess what? Usually we're not. And they figured it out. So the implications here that we've thought about is, rethink fidelity and consistent adaptations. They may not be a violation of something that might be effective. They may be associated. Ask the question, bidirectional. We don't know for sure that they're not associated with good outcomes. Figure out what's core and what is adapted and recognize what is core and what is not. There may be disagreement. And there was, as Kelly pointed out, between us, the researchers, and the purveyors, or at least for me anyway, personally. I really felt like integrating into the setting was going to be better. Ken and I had friendly debates about that. Consider equity. Here we've got disabled individuals, people with mental health disabilities, people with serious mental illness. Really think about adaptation that helps with equity and access, and then work with stakeholders to plan and guide these. Think about this proactively, which we did along the way. So this brings us to where we are today, which is that as we thought about what we learned, we observed that among the least understood aspects of implementation, research, and practice currently include the relationship of adaptations to long-term outcomes, not 6 months, long-term, And what are the factors associated with sustained delivery and the impact of evidence-based interventions? Do we know that? And we looked at the literature, and there was a lack of clear conceptualization and measurement of sustainment, lack of evaluation of health benefits of sustained, lack of theoretically informed investigations, and limited research on long-term sustain. By that we mean greater than 5 years, not 6 months, not 12 months, 5 years. Why 5 years? Because it was 5 years later we were thinking about what to do about kind of understanding this whole issue of sustainment. And, we're not the first persons to ask the question about whether or not adaptations has something to do with sustainment, right? This guy Darwin thought about this a long time ago. And this other guy, Chambers, thought about, who you know, David Chambers, who is a leader in our field and at NCI leading implementation science. And if you go down to Washington in several weeks, he'll be playing his guitar and kicking off the meeting as usual. He posed this idea of dynamic sustainability framework that maybe as the context changes, if you want to sustain something, you have to adapt. So we were wondering about that. So we put together an application. What did we learn in that application process? Persistence pays off. The first application, and I'll turn to Kelly in a second to talk about this in more detail, did well, was discussed, and we knew the gaps in the field. But in revising it, we heavily acquired outside reviews of our review of the summary critique and the application. And we really emphasized building on the unique aspects, the data that we had, the knowledge of adaptations, the fact we had this incredibly cool opportunity to go back to these organizations and look at sustainment 5 to 8 years later. So this is the next study that literally just got funded very recently. And Kelly is the lead on this. I'm the co-PI. And this built on our 2014 to 2019 hybrid effectiveness implementation. We found in 2023 that 36% of 39 of the organizations completed the study and continued to deliver in shape. And we proposed 6 years to 8 years post-implementation study to look at two dimensions, sustaining the delivery of in shape and sustaining the health benefits. And this approach leveraged the data we collected previously that you saw, examining multi-level factors to predict long-term sustainment. We also proposed to collect new data on contextual factors and adaptations and fidelity to the in-shape person, and also to look at person-level outcomes. We kind of debated that, but we decided that was important. And then to work to kind of develop something for the field, to collaborate with a national network of in-shape teams to develop a sustainment practice guide for health promotion. So this is aim one. Kelly, do you want to walk us through the aims as the lead on this? I think that's appropriate. Why don't you walk us through?
Steve, I think you can continue to
Okay, I'll
your
let you comment.
presentation. I'm happy to
Okay, all right. So
And Steve,
I will,
probably about 5 minutes, so we have at least
thank you. So I
10
will
minutes for
fly.
questions.
Thank you for the invitation. So first aim, evaluate long-term sustained delivery of in shape and identify adaptations and fidelity and contextual factors associated with sustainment using a sequential mixed methods explanatory model. And then identify multi-level factors associated with long-term sustainment of the model. So this is about delivery of the in-shape model. What predicts sustainment? Secondly, were the health benefits sustained? In other words, not just the model continued, but does it still confer health, which of course is something of great interest to all of us, particularly as me as a psychiatrist and physician focusing on this area. So were we going to see continued effectiveness with the adaptations 8 years out in terms of cardiovascular risk reduction? And then our decision was that on top of that, when we learned this, because this is largely a descriptive study, right? We're not doing an intervention. We're actually going out and collecting data to develop a guide to refine a sustainment guide for health promotion, evidence-based interventions in mental health organizations, and to use a group model building workshop approach and identify promising sustaining strategies and processes, and then evaluate this in a national in-shape community of practice. It's out there in the community. So just to summarize, this new study is, we believe, the first study to leverage a network of implementation sites to identify adaptations and organizational factors that influence long-term sustainment 6 to 8 years later of a health promotion EBI in mental health organizations. And we want to develop and iteratively evaluate a guide that will be of use to the field. The last slide here is the 20-year arc that actually is amazing to think of. But if you look at where we started, the model was developed by Ken Ju in 2002. And we did that study 20 years ago, the pilot study. And then we did the effectiveness studies, the replication studies, the initial and the replication. Then we did that statewide implementation study, and then this multi-site hybrid effectiveness implementation RCT. And now we're on to this very cool next study on long-term sustainability that we'll be doing over the coming 5 years. And those are the key people on the team. There are many others, but these are many of the people that were involved, particularly in the implementation part of this. Sarah Pratt deserves a big shout out in this, who was really the trainer and interventionist of the intervention, along with other colleagues here. With that, I'll stop.
And that was terrific. Thank
Yeah.
you so much, Steve and Kelly, for your great work and your willingness to chat with us about it. So I'm not seeing any questions in the chat yet. So let me just see if there's any hands and anybody wants to jump in with a question to kick us off. Well, I will. Nobody else will. Get your questions going. Oh, perfect. Adeline.
I'll put my camera on. Thank you so much. That was so helpful especially to see all the way from the beginning and to see the arc. Really, really, really helpful. So thank you so much. I have a question about how you managed and the team managed the funding of all of this, especially with sort of, I think when we're doing implementation research, there's like this blur between what's funding the research and the data collection activities versus funding this, like the actual service part of it activities, and particularly seeing how big these studies are. I'm just curious how you made that work. And if there was other funding from other sources and then like the sustainability of it. So
sure.
Yeah, all of those questions wrapped into funding.
Well, first of all, it was hard, but doable. I think the first implementation pilot study that we did was built kind of on the back of some of a Medicaid waiver and some other sorts of stuff that were kind of out there, and we kind of put it together, on top of some funding that we acquired. The RO1 that we did, literally, when we went out to the organizations, we said, you're going to get free training. You're going to get free supervision. You're going to get the best we can deliver in terms of helping you to implement and coach. However, there's no money in this to pay for the health mentor. That's actually the experimenting part. Can you find within your organization people that you can retask or work with your Medicaid office? I had a close relationship with the Medicaid office in New Hampshire since I was medical director, and I had kind of worked with Kelly Cappuccino, different Kelly, who's head of Medicaid, to kind of figure out a way to get rehabilitation services to kind of pay for part of it as a rehabilitation. So we knew something about that. Also, Ken Ju, who was the originator of this, met with some of the CEOs and said, I know how to fund this. Let me tell you what I did. And so they had someone of like mind who was a CEO helping to think about funding the interventionists, the people who are, but sometimes this works, particularly if you say, we're going to give training, we're going to give supervision, we're even going to pay, we will pay for, by the way, getting your people certified. I think we had in the budget, the certification to become a health fitness trainer. I think we were able to budget for that. Mm-hmm. But part of the real experiment was, can you really implement this and do this in the real world with the supports that we have?
I'll just add
And
one thought to that in terms of kind of thinking of the arc of putting a research program together. I think it really helps to know kind of like what the really big question is, like, can we improve health outcomes for people served in this area, cardiovascular outcomes, and then the individual steps along the way? Because that sort of, I thought, Steve, you just did a beautiful job laying that out. You start with the smaller question, and you take the smaller questions to the larger, and then ask, the incremental questions. And I think that makes it easier when you've got kind of a sense of what's the overarching thing that I'm trying to get to. Makes it easier to get there. I think you might have had a follow-up question, Edelyn. Sorry, I didn't mean to cut you off.
Yeah, I was just asking. So in terms of like the R1 where you were comparing the two different strategies, then when you're randomizing the organizations, have they already bought onto it and like said that they're at least going to try and then you
Yes.
randomize, or does that
Well, here's what we did. We actually work with what was called at the time the National Council for Behavioral Healthcare. It has a different name now, but it was a member organization. And we actually work with them. We paid them a little bit of money. We put out kind of like an RFA, request for applications. We made it really like this is like a really cool thing. You're going to get free training of this evidence-based practice with experts from Dartmouth. We had them help recruit and apply. And we actually had an application process. And Kelly and I looked at the different applicants and Sarah Pratt also to see whether they were likely to follow through. Could we distribute them across the country? And did they have the capacity to really do the thing, or were they just kind of passively interested? So we actually had an application process because we thought that what we're bringing to the table was really dead on, as Karen said, on a really important health problem that they knew was people were dying and not getting what they needed. And we said, this is an evidence-based practice that can help. And we know you're not doing it because no one's doing it.
Yeah. Interesting.
Great.
Thank you so much.
I think we have a question from Alexandra. Do you want to ask it, Alexandra? Can you? Yeah.
Yeah, thanks. First of all, really fascinating presentation and sort of all the nuances about what do we mean by fidelity and fidelity to what. So my question, I was very interested in the finding that when there were more adaptations, if I heard this correctly, I was listening in my car, that when there were more adaptations, that the risk reductions, the cardiovascular risk reductions were actually greater. Is that what, did I hear that correctly?
I'll let Kelly respond to that one. I believe that's technically correct, but there was a specific type of adaptation that made a difference. Go ahead, Kelly.
The one where they had the center in the building where the people came. Yeah.
Correct. That seemed to be the thing that drove this difference, this fidelity inconsistent. So it's in a way, the nuance here is even though it's fidelity inconsistent, if you ask me, is having an exercise program that's integrated into the mental health center along with health inconsistent with cardiovascular risk reduction? I would say no. But the purveyor said, no, no, no. Social inclusion, working out in the gym, in the community of health with people who are not stigmatized with mental illness is central to this intervention, core to the intervention, Steve.
Yeah, no, that's a fascinating dichotomy. I think my follow-up question was really when you look over the longer period of time, did the organizations that put the gym in their center, did the health gains continue over a longer period of time relative to the ones that followed the original model where the gym was in the community?
We
Well,
hope
we
to.
don't know that yet.
No.
And we're going to learn so much, I can tell already, from meeting with both the sustained and the unsustained site, which I'm doing, and meetings with all of them. We're going to learn so much that's just going to blow our minds about adaptations, what they mean, what sustainment means, what are you sustaining? What are you talking? People just don't want the brand, for example, anymore. They're done with InShape. InShape's a proprietary. Someone owns it. You have to pay them to train. But now that they know what to do, they'll say, we don't have InShape. We've discontinued InShape, but we've got this program. And it looks a lot like, and we're collecting for the sites that agree we're collecting. They are submitting routinely collected, de-identified InShape client data on weight and fitness. So we'll have some data to actually look at in addition to just sustained delivery of a model. So I think it's it's really exciting for me to being a person who's studied adaptations for a while is to think about, just to help us all think about what do we really mean when we study and we say adaptations? What do we really mean when we want to sustain? Is that black or white? Is that a continuous thing? Is that what part are we looking at? So I think it's going to be really exciting. We're all going to learn a lot from the new study.
Thank you.
And
Yeah, Kelly, just to pick up on that, I think there are a couple of really interesting things there. I mean, one of the things I've heard that finding before, and as Steve was talking about it again today, I was wondering about, could you almost imagine in the future having two fidelity measures, one that the program purveyor believes and one that you believe really, because you have two different goals, right? His goal was to basically around inclusion. Your goal was around just improve their health. And so it's a really interesting question about, I think, how one defines that and whether there could be competing measures of fidelity. The other thing I wondered if you guys could speak to, because I think it comes back to this hybrid 3 issue. You have so many health centers or mental health centers, and that is, I think when you're doing a hybrid 3, you kind of have to go there. So it's a giant lift. And especially when you're talking about sustainability, the turnover piece is so critical. And I'm curious to know what you've learned so far and how you're thinking about that as you look at sustainability.
Yeah, that's a great question. I'm glad you asked that because the 14 centers I've met with so far, they all have the same team that we trained
Amazing.
in 2016. It's like, oh, what's the main factor that continues to stay? It's like the same health mentor leaders and almost all of if not all of them. It's just really neat to think about sustainment. And so then it's like part of what we want to understand when we do the qualitative interviews with the discontinued or the evolved sites. It's like, was staff turnover? What happened to those mentors? Do they have to take another position in the agency? And yeah, I think that's a really important question and something we're anecdotally finding just in our engagement meetings we're having now.
And the last lesson learned I just want to put on the table is those of you who are clinicians, make sure that you pair yourself with a brilliant methodologist who actually got a PhD. And those of you who are PhDs, think about also whether some of these medical issues, these health issues, you can benefit from partnering with someone who's really deep in the medical issues or in the administration. As a medical director, ran health systems and had these relationships with leaders, CEOs. And so these sorts of partnerships are essential to this type of work. It's a team sport. There's no way that I could have done any of this stuff without Kelly. And hopefully I was somewhat helpful. I will be helpful to Kelly on this study going forward. But these partnerships are really essential. It's a team sport, really, and we bring different things to the table.
Thank you so much. This was such a fantastic session. And I just want to remind people in the chat, the recording is there, and I think it gets posted as soon as we get it done and then finalized. And there is, now I'm looking for the chat is moving as there we go. On the 17th, an early Christmas present will be a session with Dr. Jessica Haber from the MGH Center for Global Health, presenting on the importance of integrating data science and implementation science for global impact. So that's going to be a really focused, but will have huge implications for all that we do. So we're really excited about that. Hope everybody has a wonderful Thanksgiving, and we will see you next month. Thanks again, Steve. Thank Kelly.